Antimicrobial resistance in healthcare. Threat to the healthcare profession and humanity. The spread of antimicrobial resistant, AMR, bacterial and fungal pathogens within healthcare facilities has reached a crisis level, posing one of the most serious threats to modern society. These pathogens colonize equipment, scanners, walls, beds, and furniture, endangering not only patients but also healthcare workers, visitors, and society as a whole. Global health authorities, including the World Health Organization and the Centers for Disease Control and Prevention, have issued urgent warnings but have not offered any solutions to this growing crisis. The silent invasion of healthcare facilities. Healthcare environments have become reservoirs for antibiotic-resistant organisms, with contamination spreading beyond patients to the entire built environment. Research shows that hospital surfaces, medical equipment, and infrastructure serve as persistent reservoirs of dangerous pathogens, perpetuating a cycle of transmission. The scope of environmental contamination. Comprehensive surveillance studies have revealed concerning patterns of environmental colonization. In both newly constructed and established intensive care units, ICUs, antibiotic-resistant organisms form persistent colonies on various surfaces, with sink drains exhibiting the highest load of resistant pathogens. Pseudomonas aeruginosa, one of the most frequently cultured organisms from hospital surfaces, can create biofilms that resist standard cleaning procedures and biocides, persisting for extended periods. Contamination affects critical medical equipment and devices. Between 60% and 80% of hospitalized patients with medical devices receive antimicrobial agents, which often promote resistance in colonizing organisms. Devices such as urinary catheters, intravascular catheters, orthopedic implants, and surgical instruments can harbor biofilm-forming bacteria that display high resistance to both antimicrobials and the body's immune defenses. A particularly alarming discovery is that colonization with antibiotic-resistant organisms can happen even before patients occupy a space. Studies of newly constructed ICUs found that resistant organisms, particularly Pseudomonas aeruginosa, colonized sink drains and other plumbing systems before any patients or staff entered the facility. This indicates that hospital environments can serve as incubators for resistant pathogens, independent of patient-to-patient transmission. Various environmental factors help sustain AMR pathogens in healthcare settings. Biofilm development on surfaces forms protective barriers that make bacteria up to 1,000 times more resistant to antimicrobials than free-floating cells. These biofilms can persist on medical equipment, hospital furniture, and infrastructure for extended periods, continuously releasing resistant organisms into the environment. Traditional chemical sanitization methods are inadequate, with over 50% of surfaces still not properly decontaminated even after standard cleaning. Research indicates that although cleaning temporarily reduces bacterial levels, recontamination happens swiftly, often within hours, as resistant organisms regenerate colonies from protected reservoirs that multiply every 20 minutes. Healthcare workers, such as doctors and nurses, and local chemist department stores selling drugs, face unprecedented occupational risks from continuous exposure to antimicrobial-resistant organisms. This threat extends beyond doctors and nurses, to include all individuals working in healthcare environments, such as sanitation staff, laboratory technicians, transport personnel, and administrative workers. Healthcare workers are constantly exposed to resistant Mycobacterium tuberculosis, AMR pathogens through various routes. During routine patient care, such as bathing, mobilizing, toileting, and transporting patients, workers make direct contact with resistant organisms. Studies have shown that drug-resistant bacteria colonize healthcare workers' hands at rates similar to those on environmental surfaces, confirming that workers act as both recipients and carriers of resistant pathogens. The risk is higher for workers caring for patients with indwelling devices, those undergoing antibiotic treatment, or those in ICU settings, where resistant organisms are most common, because these organisms are resistant to chemicals that claim to kill microbes. Companies selling air purifiers that claim they reduce bacteria, fungi, and viruses are not credible. This equipment can increase the spread by allowing organisms that spread by contact to become airborne. Nursing aides and support staff, who often perform the most personal patient care tasks, face particularly high exposure risks, but may have less access to protective equipment and training than licensed medical professionals. Antimicrobial resistance in healthcare. Threat to global society. The spread of antimicrobial resistant bacterial and fungal spores within healthcare facilities is one of the most serious threats facing modern society. These pathogens infect equipment, scanners, walls, beds, and furniture, jeopardizing not only patients but also healthcare workers, visitors, and the wider community. Global health authorities, including the World Health Organization and the Centers for Disease Control and Prevention, have issued urgent warnings about this growing crisis. The silent invasion of healthcare facilities. Healthcare environments have become reservoirs for antibiotic-resistant organisms, with contamination spreading beyond patients to the entire built environment. Research shows that hospital surfaces, medical equipment, and infrastructure serve as persistent reservoirs of dangerous pathogens, perpetuating a cycle of transmission. The scope of environmental contamination. Comprehensive surveillance studies have revealed concerning patterns of environmental colonization. In both newly constructed and established intensive care units, antibiotic-resistant organisms form persistent colonies on various surfaces, with sink drains exhibiting the highest load of resistant pathogens. Pseudomonas aeruginosa, one of the most commonly cultured organisms from hospital surfaces, can produce biofilms that resist standard cleaning procedures and endure for long periods. There may be bacteria and fungi that scientists have not yet discovered. My institution made me visualize 3I Atlas, the third interstellar object to enter our solar system in recorded history. Observing such a rare event may be extremely valuable, but I believe it could have delivered microorganisms that help antimicrobial-resistant organisms mutate into more virulent strains. Research shows that bacteria in space can change their gene expression and behavior, with some studies indicating increased virulence and antibiotic resistance. This, along with astronauts' weakened immune systems during spaceflight, presents a potential health risk, especially on long-term missions. Recognizing encounters with 3I Atlas in space is essential. Contamination impacts vital medical equipment and devices. Between 60 and 80% of hospitalized patients with medical devices receive antimicrobial agents, which often encourage resistance in colonizing organisms. Devices such as urinary catheters, intravascular catheters, orthopedic implants, and surgical instruments can harbor biofilm-forming bacteria that show high resistance to both antimicrobials and the body's immune defenses. When I invented, tested, and proved the endotracheal tube fixation device and the spring-loaded intravenous cannula, I anticipated the spread of ARM, which would bring us to our knees. Device manufacturers claiming my devices de-skill doctors, I was disappointed, but knew the healthcare providers are not noble but hoarding wealth, and not interested in protecting or preventing infections or illness.
A particularly concerning discovery is that colonization with antibiotic-resistant organisms can occur even before patient occupancy. Studies of newly built ICUs found that resistant organisms, especially Pseudomonas aeruginosa, colonize sink drains and other plumbing infrastructure before any patients or staff entered the facility. This shows that hospital environments can act as incubators for resistant pathogens independent of patient-to-patient transmission. Multiple factors contribute to the persistence of AMR pathogens in healthcare settings. Biofilm formation on surfaces creates protective barriers that make bacteria up to 1,000 times more resistant to antimicrobials than free-floating cells. These biofilms can survive on medical devices, hospital furniture, and infrastructure for extended periods, continuously shedding resistant organisms into the environment. Conventional chemical sanitization methods have proven inadequate, with over 50% of surfaces remaining insufficiently decontaminated even after standard cleaning procedures. Research indicates that although cleaning can temporarily reduce bacterial levels, recontamination occurs swiftly, often within hours, as resistant organisms regenerate colonies from protected reservoirs. The occupational threat to healthcare workers and support staff. Healthcare workers face unprecedented occupational risks from ongoing exposure to antimicrobial resistant organisms. This danger extends beyond doctors and nurses to include all personnel working in healthcare settings, such as sanitation staff, laboratory technicians, transport personnel, and administrative workers. Healthcare workers are continually exposed to AMR pathogens through various routes. During routine patient care, such as bathing, mobilizing, toileting, and transporting patients, workers come into direct contact with resistant organisms. Studies have demonstrated that drug-resistant bacteria colonize healthcare workers' hands at rates similar to those on environmental surfaces, confirming that workers serve as both recipients and carriers of resistant pathogens. The risk is higher for those caring for patients with indwelling devices, those on antibiotic treatment, or those in ICU settings where resistant organisms are most prevalent. Nursing aides and support staff, who often perform the most intimate patient care tasks, face particularly high exposure risks, but may have less access to protective equipment and training than licensed medical professionals. As antimicrobial resistance, AMR, spreads and healthcare environments become increasingly dangerous, the industry faces the risk of a workforce collapse. Healthcare workers who become colonized or infected with resistant organisms may need extended leave, treatment with toxic antibiotics, or even decolonization protocols. The psychological strain of working in settings where common infections can become potentially lethal adds to the already high levels of burnout and attrition within healthcare professions. Lower paid healthcare workers, such as nursing assistants, sanitation workers, and food service staff, face high exposure risks but often have limited access to healthcare. This can lead to them leaving the profession entirely, resulting in critical staffing shortages when healthcare systems need to operate at full capacity to address the AMR crisis. Economic devastation and societal transformation. The economic repercussions of unchecked AMR extend far beyond healthcare costs, endangering global financial stability, efforts to reduce poverty, and vital societal structures. Current forecasts paint a grim picture of AMR's economic effects. The World Bank estimates that under a business-as-usual scenario, AMR will increase global healthcare costs from $66 billion per year to $159 billion by 2050. In a high-resistance scenario where rates rise at the speed of the bottom 15% of countries, healthcare costs could reach $325 billion annually, and the global economy could be $1.7 trillion smaller by 2050. These figures only cover direct healthcare costs. The broader economic impact includes loss of labor force participation, decreased tourism and hospitality revenue, reduced agricultural productivity, and restrictions on international trade. Earlier projections warned of cumulative losses nearing $100 trillion over 35 years if resistance remains unchecked. The economic burden falls disproportionately on low and middle-income countries, LMICs, which could face losses exceeding 5% of their GDP and see around 28 million people pushed into extreme poverty by 2050. These countries face challenges such as high resistance rates, limited access to newer antibiotics, and fragile healthcare infrastructures that are least equipped to handle the crisis. Impact on food security and agriculture threatens global food security in multiple ways. The widespread use of antimicrobials in agriculture and animal husbandry promotes the development of resistance, while resistant pathogens can contaminate food products throughout the farm-to-table process. Workers in food production are directly exposed to resistant organisms, and consumers face the risk of infection from contaminated food. It's not just bacteria, it's a fungal infection that worsens the situation. Stored food, hands, body, and feet of the farmers can stop them from working, making billions of poor people starve and die. Food safety breaches caused by AMR create a vicious cycle of deteriorating health, malnutrition, and food insecurity. When resistant foodborne pathogens cause illness, treatment failures increase, leading to prolonged illness, inability to work, and decreased economic productivity. The risk of resistant outbreaks in food animal populations could devastate entire herds or flocks, reducing food supply and raising prices, making safe food inaccessible to poorer communities. The threat of AMR extends to critical infrastructure and essential services that depend on a healthy, functioning workforce. As AMR renders common infections untreatable, workers across all sectors face increased sick days, disability, and death. This situation impacts not only healthcare but also education, transportation, manufacturing, agriculture, and public services. Sanitation infrastructure becomes especially crucial as inadequate wastewater treatment propagates resistant organisms in the environment. Hospitals and pharmaceutical manufacturers discharging untreated or poorly treated wastewater into the environment create hotspots for the development of resistance where bacteria can exchange resistance genes and evolve new survival strategies. In a post-antibiotic era, AMR affects the public, leaders, and communities worldwide, signaling a fundamental shift in daily life and creating conditions not seen since the discovery of antibiotics. Without effective antimicrobials, infections that are now minor inconveniences could become life-threatening emergencies. A simple urinary tract infection, a child's ear infection, or even a small cut or a thorn prick could lead to sepsis and death. Recently, I was shocked to hear that doctors working in the ITU are using artificial intelligence to help diagnose sepsis. The doctors have failed to understand the pathophysiology of sepsis, so they cannot prevent full-blown sepsis, but they only think of diagnosing sepsis using AI once symptoms appear. The World Health Organization warns that we risk entering a post-antibiotic era, in which common infections and minor injuries that have been treatable for decades can once again be fatal. The human toll is concerning. Current estimates show that bacterial AMR caused 1.27 million deaths in 2019 and was linked to 4.95 million deaths worldwide. Projections show that leading universities and research institutions have provided strong evidence that antimicrobial resistance is an increasing crisis with pandemic potential. The Lancet's landmark study on the global burden of AMR, conducted in collaboration with institutions worldwide, predicts that AMR-related deaths could reach 8.22 million annually by 2050, leading to 39 million lives lost between 2025 and 2050. The study highlights that without additional interventions, the world will not meet the proposed 10% reduction in AMR mortality outlined in international targets. Research from Johns Hopkins University emphasizes that AMR threatens the effective prevention and treatment of an expanding range of infections. The prevention epicenter at Johns Hopkins is dedicated to developing strategies to prevent healthcare-associated infections and improve antibiotic use, as prevention is recognized as the most effective method to combat AMR. Research from European institutions warns that the COVID-19 pandemic is likely accelerating AMR due to increased antibiotic prescribing, disrupted antimicrobial stewardship programs, and overwhelmed healthcare systems. Data show that nearly 75% of COVID-19 patients received antibiotics even in the absence of confirmed bacterial co-infection, which may promote the development of resistance. Cambridge and Oxford universities have established research networks specifically targeting antimicrobial resistance, AMR, focusing on next-generation strategies such as new diagnostics, alternative therapeutics, and improved surveillance methods. These efforts recognize that AMR presents an escalating crisis requiring urgent, coordinated global action across scientific, clinical, and policy sectors. According to medical ethics, doctors are not allowed to conduct tests or investigations to diagnose rare illnesses or infections if there is no available treatment, no way to prevent complications, or no way to manage complications or death. The law of the universe clearly states that we humans must not harm the physical or mental well-being of another soul. By performing tests, doctors cause the person to suffer in silence. The path forward involves introducing intervention scenarios and aims to reduce suffering, although projections for AMR remain grim. Substantial evidence indicates that coordinated global efforts can significantly decrease its impact and save millions of lives. Unfortunately, people and healthcare professionals have not recognized or implemented the only system capable of preventing and protecting humanity: early detection at the community level through symptom and sign identification before hospital overload. Immediate isolation can prevent 30 to 50% of transmission events. Proper care routing reduces empiric antibiotic failures by recognizing patterns. Resource allocation prevents ICU overflow, which can be fatal even to patients with susceptible infections. ChatGPT estimated a reduction of 12.3 million lives by 2050. Economic modeling indicates that investing in AMR interventions can yield significant returns. Enhancing innovation and access to high-quality treatment for bacterial infections would require approximately $63 billion annually. It could produce a 28-to-1 return on investment, translating to $990 billion in global economic benefits by 2050. Comprehensive measures combining improved treatment access, innovation in new antibiotics, expanded vaccination programs, and better water, sanitation, and hygiene (WASH) could save up to $99 billion annually in healthcare costs by 2050, while contributing $960 billion to global economic output. These initiatives could prevent between 92 and 110 million deaths from 2025 to 2050. Several studies highlight that preventing infections is the most effective way to fight AMR. By stopping infections, there is less chance that resistance will affect health outcomes, and lower infection rates mean fewer people need antibiotics, which decreases the pressure for resistance to develop. Key prevention strategies include 1. Enhanced infection prevention and control, IPC, in healthcare facilities, targeting 90% of countries to meet the WHO minimum IPC standards by 2030. 2. Improved access to WASH infrastructure, especially crucial in low and middle-income countries, LMICs, where contaminated water and poor sanitation contribute to AMR transmission. 3. Broaden vaccination coverage to prevent bacterial infections and decrease reliance on antibiotics. 4. Environmental measures, including effective wastewater treatment and pharmaceutical waste management. Research indicates that access to clean water and proper disposal of fecal waste are crucial for conserving antibiotics for human health, offering a practical intervention that tackles multiple routes of resistance transmission. In India, I see people continue to defecate and urinate in populated areas, drainage, and banks of rivers and ponds. A problem that should have been addressed soon after independence has escalated into a crisis that cannot be fixed. The emergence of the New Delhi metallo-beta-lactamase 1 (NDM1) enzyme, carried by various bacteria that are not monitored or addressed, is likely to make India the epicenter of future epidemics and pandemics. Robust surveillance systems provide essential data for monitoring the development of resistance and guiding practical actions. The WHO Global Antimicrobial Resistance and Use Surveillance System (GLASS) has expanded from 25 to 104 participating countries, yet nearly half of the member states, including India, do not report data. Goals include ensuring that 80% of countries can perform bacterial and fungal resistance testing by 2030, and that all nations report quality surveillance data on AMR and antimicrobial use. Investment in laboratory infrastructure, diagnostic capacity, and data systems is vital for tracking progress and implementing evidence-based interventions. I feel sad because the leaders, university chancellors, and deans of medical and nursing schools have not considered that antimicrobial resistant infections shake the very foundation of modern medicine. Students who qualify as doctors will not be able to offer their services and do not think their family or their lives are at risk. Ensuring proper antibiotic use through a stewardship program was considered essential for reducing AMR, but this has not produced results because the system that protects doctors and nurses who follow protocols and guidelines does not protect honest doctors who do not abuse antibiotics. When I asked the lead doctors who manage NHS 111 in the UK to share information about presenting complaints and the actions taken by the nurses, doctors, and chemists who triage patients so that I could compare the quality of care offered, he refused and reported me to the General Medical Council to protect his institution. During COVID-19, I stated that using fever as a criterion to prevent people from traveling, socializing, or working is unethical. Doctors have not identified a temperature threshold that reliably distinguishes between fever caused by viruses, bacteria, or normal physiological processes. As a doctor, I have worked for more than 40 years in pediatrics, where most children are rushed to the hospital when parents notice a fever because they fear fits. We know that fits occur only when the body temperature rises rapidly. Therefore, many parents do not recognize fever. I have never seen a child fit due to hyperthermia, nor have I seen a child with intracranial bleeding present with hypothermia, so it is likely to be very rare. I hope this podcast and video helped you learn more about modern medicine. When I meet people and explain, some assume I am crazy, others wish to motivate, but no one has come forward to help me move forward. Let me tell you, I am 71 years old, have traveled all over the world, and lived a comfortable life with my family and daughter. I am proud and will die peacefully one day, saying I have completed the task I was born for. No human or God can blame me for the crisis humans created, ignored, and will one day realize I was right because I did not watch the evil people destroy the world. I acted and experienced loneliness, poverty, and suffering, but with no regret.